event with the title Patient Blood Management. Why should I introduce this concept to my hospital? Our speaker will be Professor Axel Hofmann, and you will of course have the opportunity to ask questions. But first, I want to give you some additional information. This presentation is accredited, so you will get 1.5 credits. If you need those credits, please click on the button Credits anfragen. Then, regarding the questions, on the upper left corner, you will see 4 lines. Please click on the 4 lines and then click on questions, and then a new window will open and you will see where you can enter the questions. As this event is being held in English, we would be glad if you can also enter the questions in English, which makes it easier for us. Also, for your information, this web-app was produced in cooperation of Vifor, Groupe Mutuelle, and Alliance Rouge. My name is Sandra Mathieu. I'm your moderator tonight. And now I'm very happy to say some introductory sentences about Professor Dr. Axel Hofmann. Axel Hofmann is a doctor of medical science with a master's degree in economics. He is adjunct professor at the Faculty of Health and Medical Science, the Division of Surgery at the University of Western Australia, and visiting professor at the Institute of Anesthesiology at the University Hospital here in Switzerland. He is one of the originators and international key opinion leaders of patient blood management, which is the topic of tonight. His focus is patient blood-related clinical and health economic research. Another important activity of his is the implementation of patient blood management programs in the public health sector and in large hospital systems. He currently also serves as chair of the World Health Organization's working group to develop a guidance for the implementation of patient blood management. He has published in international peer-reviewed medical journals, and he has also been invited to present his work in more than 60 countries and more than 400 international forums and events. He is also a founding member of the Society for the Advancement of Blood Management, where he currently serves as an advisory board member and where he served as a member of the board of directors from 2001 until 2004. He is co-founder of the International Foundation for Patient Blood Management, where he serves as a board member. Also, he's a member of the Austrian Society for Anesthesiology, Intensive Care and Reanimation. Professor Hofmann, it is an honor to have you with us tonight, and we are looking forward to your presentation.
Thank you, Sunjoy, for this most kind introduction, and good afternoon. Good evening to everyone joining us tonight or this evening. Just let me prepare the laser pointer and then we can start. Okay. Patient blood management, why should I introduce this concept in my hospital? Here's my disclaimer slide. Working with governmental and public institutions, blood services and professional societies and NGOs, and also with industry partners. A brief introduction. This is a chart of the earnings before income tax and depreciation and amortization of the larger hospitals in Switzerland from 2019 to 2020. And you can see that the margins are reduced. We all know that COVID put quite a stress on the system. Some of the hospitals turned from positive into negative figures, into losses. And here's a slide from the McKinsey Group looking at the practice of chief executive officers with exceptional track records. And they found that the CEOs with an exceptional track record compared to the overall group of CEOs being in that poll, that they were probably successful because early on in their tenure, they undertook a strategic review and they started with cost reduction programs. And these are the areas where they had a lesser interest. Not to say that they didn't have an interest in it, but their focus was on the two top ones. And I think with what I'm going to show you today, we are addressing exactly the strategic position of your hospital, and also showing the potential for an enormous cost reduction program. Reducing mortality and morbidity while saving costs. This is something that we don't have too often, because usually when you want to improve your services, you also have to add costs rather than saving. However, here in all emergency and elective medical and surgical patients in 4 tertiary hospitals in Western Australia from 2008 to 2014, where we included 605,000 patients into this observational analysis, we saw a reduction in this ultra-modern hospital system of in-hospital mortality of 28%. We saw a reduction of hospital lengths of stay of 15%. The rate of nosocomial infection dropped by 21%. That for myocardial infarction, stroke by 31%. With a little bittersweet taste at the end, the readmission rate increased 6% from a baseline of, I think, 1.2 or 1.3%. And we saw this with a reduction of blood product costs in about 18 million Australian dollars, activity-based costs related to transfusion services of about $80 million, and additional savings from these significantly improved outcomes. And the question is, how did we do this? Well, we did it by applying patient blood management, and here's the original definition. It's an evidence-based bundle of care to optimize patient outcomes by managing and preserving a patient's blood or own blood. We'll get later on towards the end of this presentation to a revised definition. Anyway, but before we talk about patient blood management, or the acronym PBM, we want to go through 2 blocks of that lecture. The first one is the macro view, understanding the 21st century healthcare challenges, which includes the macroeconomic dynamics of the global healthcare sector, the great tsunami, the imperative for the healthcare sector, especially for administrators. And we also want to show where something is going terribly wrong. And we want to show 3 examples in healthcare where things go wrong on a massive scale. And once we have looked at this from this macro perspective, we will have a micro view on the role of patient blood management to mitigate the healthcare crisis. We want to look at the cost of anemia, blood loss, and transfusion in your hospital, hypothetically, the rationale behind PBM, and the multiple wins with PBM. So that's our program for tonight. And let's start with block number 1 and the first sub-question, the macroeconomic dynamics of the global healthcare sector. What you see here is the health expenditures relative to the gross domestic product of all these countries on the bottom. And it's useless to single out one, but what you see is there is a a constant increase of health expenditures from somewhere around 5% to meanwhile somewhere about 9% over almost 40 years. So that was the era of abundance. But then we had the global financial crisis, and you see that the growth rate has kind of stalled. However, with the advent of 2019, we see again an increase, and you see this is some countries have not yet their numbers out, but we can see that in all these and almost all of these countries, we have a steep or very steep increase of expenditures relative to the GDP in the healthcare sector due to COVID. However, the healthcare sector is in competition to the housing, the food, the transportation, education, etc. sector, and it can't go on like it went on for decades. There is a limit, and we obviously have reached the limit, except the United States. They're almost at 17% of GDP now. But this is a situation of unsustainability. And here's an article by Kwahane, A Glimpse of the Next 100 Years in Medicine, saying the era of shifting more and more economic resources towards healthcare is going to an end. And here's the great tsunami that is basically exacerbating the situation. This blog from quite a while ago from the former public health, former US Assistant Surgeon General, baby boomers, public health's biggest challenges. This is in fact the great tsunami. And some of you in the audience might be familiar with this name, William Haseltine. He's one of the public health gurus, if you will, in the School of Public Health in Harvard, and one of the architects of healthcare reforms around the globe. And in his article in Forbes, Aging Populations Will Challenge Healthcare Systems All Over the World, he says, and this is some of the excerpts of that article, demographic change is a defining issue of our time. As the worldwide population ages, the healthcare systems of every country will face significant challenges to meet the needs of an aging population. And between 2015 and 2030, the number of people in the world aged 60 years and older is expected to grow by 56%, from 0.9 billion to nearly 1.5 billion. And by 2050, it will jump to 2 billions. So as a conclusion, he says, as societies age, all those involved in the healthcare and social care systems must adapt their services and continuously learn. And here's the great tsunami in a picture. This is created by Gapminder. What you see on the x-axis is the life expectancy. This is the year 1970. You see Japan, or here Switzerland, had a life expectancy of about 73 years, and there was a little bit over 10% of the population in Switzerland age 65 and older. Now, about 50 years later, or 49 years later, we see a life expectancy of almost 85 years, both in Japan and Switzerland, and you see the population age 65 and older has almost tripled, which means you have a higher surgical volume and you have more non-communicable diseases. You might have seen this curve oftentimes. On the x-axis, you have the age of the population segments, and on the y-axis, the share of persons surviving to given age. And you can see the increasing survival rate. The best times of increasing are gone. This was from 1850 to about 1950. Meanwhile, most of the children and neonates are surviving, but what is increasing is the longevity. And this in combination creates what we call the Great Tsunami. You might also ask, why does it all stop at 120 years? Well, it's probably interesting to know. Here's Leonard Hayflick, who demonstrated a long time ago that the maximum age in humans is about 120 years due to the number of telomeres, or the length of the telomeres defining the number of mitoses. Coming back to our curve, semblewise, what is impact on childbed fever certainly made a change. He unfortunately never realized that he did, because they according to records, they were beating him to death, and locked him away because he felt he's insane. Even Virchow, until the late 1800s, didn't realize that Semmelweis was right. Anyway, Louis Pasteur made a change with the vaccination disruption, Fleming and colleagues with penicillin. And now we think that we are heading towards a rectangularization of health with all these, let's say, interesting new areas, including machine learning, artificial intelligence, prehabilitation, and many other things. And I found this somewhere in the internet. This is what people want to do. They want to jump into the sarcophagus in a relatively healthy condition. Now, the problem is centenarians also disease before they pass away. Here's a study that looked at the centenarians that passed away and all were succumbed to disease. So they did not just fall asleep and went. And so when we look at the current disease-free survival curve in society, here that is what we would call the morbidity boundary. Then you have a disability boundary, and finally you have a mortality boundary. And the all-defining question is, how will these boundaries behave in the coming years? Will the shape be like this? Will it be like this? Will it be like this? There are 2 or 3 schools of thought about the longevity increase. One is the compression of morbidity hypothesis, saying that individuals continue to enjoy their quality of life for quite some time. Morbidity and disability boundaries are faster pushed to the right than the mortality boundary. So that's one school of thought. The other one thinks there's an expansion of morbidity. Morbidity and disability boundaries remain more or less, while mortality boundary shifts to the right, which means we would have to care for an overproportionate amount of disability and morbidity. And then there is a middle ground called the dynamic equilibrium hypothesis. So we really don't know what the future holds. There is obviously a trend towards the compression idea or concept, but what we have to keep in mind here is the GDP percentage per capita spent for healthcare, from the 2-year-olds to the almost centenarians. And you see here at the age of 62, 67, we usually, at least in Central Europe, stop our working life, at least as employees, as clerks or whatever, but the big chunks of healthcare consumption are coming afterwards. And so the question with the Great Tsunami is how much disease and disability comes with it, how much does it really cost, how much is affordable from a societal perspective. In other words, who is going to pay for this and what's the willingness to pay? And if we think this can be compensated by technology, well, let's have a brief look into the past. Here's life expectancy versus GDP per capita from 1800 to 2012. So let's look at the year 1950, depending on, this is the red curve, depending on the GDP per capita in various countries, you could reach here at the peak with a GDP of a little bit over $10,000, an age of 71 years. About 30 years later, you could add 3 more life years at the same amount. So there is obviously a technological improvement. And another 32 years from 1980 to 2012, you add another 4 years. But if you really want to use or want to look at very rich societies with a very high GDP, well, we can move here to about 30,000 GDP per capita. You add probably another 4 years by multiplying the expenditure by about 3 times. So you see, this is called, by the way, the Preston curve. There is a diminishing return of investment in life expectancy. And there is a very slow upward shift of the curve. So every other 3 decades, you have this shift, or you can say a decade goes with probably one year of additional life expectancy. But it's really a slow push with scientific and technological progress, with the economies of scale, education, and nutrition. So that brings us back to what to do with that situation. You know, regardless how we look at it, and even if the compression model will be the prevalent model rather than the expansion model, how will we handle this enormous burden of the great tsunami? And the imperative for the healthcare sector, and we come back to this article to Korhane, his second statement is, the medicine of the future will focus on more efficient use of resources. And you might say, well, this is a no-brainer, isn't it? We know that anyway. Well, we don't need that lecture, not from Hofmann and not at this time of the day. However, even if it's no-brainer, it is a no-brainer. Obviously, productivity doesn't work in the healthcare sector. Here's data from McKinsey over 17 years over the improvement rates of productivity. And you can see here on the bottom, healthcare is not doing well. And productivity, by the way, is defined as output divided over input. So the Institute for Healthcare Improvement says we need methods for researching innovative ideas and assessing their potential for advancing quality improvement. And you might have heard of the triple aim: simultaneously pursue the 3-dimension, improving patient experience in terms of quality and satisfaction, improving the health of populations, and reducing the per capita cost of healthcare. And again, you would say, well, this is a no-brainer. It's all clear that we have to do this, but the question is how to do this. And before we go on the how to, we want to give you some examples why this whole productivity imperative is not working too well. This is a graph from the Institute of Medicine in the US, which is now the Academy of Science, the Academy of Medicine in the US. In 2009, they were spending 2,500 billion US dollars. Currently, it's about 4,000 billion or 4 trillion. They found that about 765 billion or 30% of the total spending is just waste. And it is sad enough that exactly in 2009, the total healthcare spending of France, Germany, and Italy was 765 billion. So in other words, what the US is wasting has been spent in these biggest countries of the post-Brexit European community. And of course, this also includes probably 30% of waste. And now they broke it down into all these factors. And another article around that time, a bit later in the British Medical Journal, spoke of the death toll of what's going wrong. And they looked at the causes of death. All causes in the US was about 2.6 million, of which 250,000 were due to medical error. So they say, based on our estimate, medical error is the 3rd most common cause of death in the US, is almost half of the cancer one. So you have to be afraid of cancer, but you also have to be afraid of your healthcare system. And this is all corroborated by what the WHO says in its Global Health Expenditure Atlas, that, for instance, in 2011, 6.9 trillion of the world's healthcare spending had included a waste rate somewhere between 20 and 40%. So you see, regardless whether we deal with compression or expansion, I think our problem is more on the waste side before we speak about optimizing the future. And here is now a more, let's say, detailed schematic on how things could go wrong. Let's assume, and again, this is schematic, this is the total population of whatever country, let's say Switzerland. And let's assume this is the healthy population in terms of no symptoms and signs. And this is the population part that is unknowingly sick, doesn't recognize any symptoms or signs. And then there are people who feel their sickness. And there are permutations because people either do not want to see a doctor or don't see the need for a doctor, or see doctors just for routine checks, or sees doctors because he is, for instance, in pain. So these are all the possibilities. And here's the classic, you have a problem, you see a doctor. And then let's assume that some of them are not diagnosed for whatever reasons and not treated. Then others might be misdiagnosed, not treated, and mistreated. Others might be underdiagnosed, not treated, mistreated, undertreated, overtreated. And others might be overdiagnosed and not treated, mistreated, undertreated, overtreated. And then there are some who might be evidence-based diagnosed and evidence-based treated, but they also could fall into that group. And finally, there might be some who are diagnosed on the current best evidence and treated on the current best evidence. So you can see why many things can go wrong and are going wrong. And so if we increase the complexity of the model with referrals and multimorbidity and non-compliance, you can imagine how much more can go wrong. And when we go from left to right, we clearly have a problem with morbidity, mortality, and resource utilization here and less here. And this is the area of system failures and therefore failed services. And so you can be lucky if you're here or here as a patient. So there was a landmark paper in the New England Journal of Medicine already 1991, 30 years ago, Incidence of Adverse Events and Negligence in Hospitalized Patients, the Harvard Medical Practice Study 1. They found that among the estimated, among the 2.7 million patients discharged from New York hospitals in 1984, there were about 27,000 adverse events involving negligence. And this led then to this call to action booklet of the Institute of Medicine, First do no harm, to err is human, and starting with the statement, errors are costly in terms of loss of trust in the healthcare system. And here more common, errors are caused by faulty systems, processes, and conditions that lead people to make mistakes or fail to prevent. Healthcare is a decade or more behind many other high-risk industries. And so I want to show you 3 of these examples that lead us right into the patient blood management alley. It is blood loss and bleeding that induces, exacerbates anemia. Anemia and iron deficiency, at a certain level of anemia, there's transfusion released and administered. And in some patients, you have an association with rebleeding after administering the transfusion. And this is posing a triad of independent risk factors for adverse outcomes. And you will see in a moment why this is big. Anemia is a condition that 1.9 to 2.4 billion people is affected from. So about 1/3 of the world population has anemia. And anemia has multiple negative consequences in terms of productivity, cognitive development, and other things. It increases the adverse outcomes for hundreds of millions of medical and surgical patients. It is associated with poor performance of tens of thousands of hospitals worldwide. And it has also huge socioeconomic consequences. In some countries, like Bangladesh, anemia is responsible for about 8 to 9% of the GDP loss of that country. And then poorly controlled blood loss, which is meant as avoidable unnecessary blood loss, which is highly prevalent in medicine, surgery, and in obstetrics. And it also leads to adverse outcomes for hundreds of millions of medical and surgical patients, again, associated with poor performance of tens of thousands of hospitals in terms of their economic results and the quality and safety. It means wasting of health economic resources, unnecessary burdens to the blood donors, impaired pandemic response, and it leads to more anemia. Here's the example of maternal mortality. The odds to die from severe anemia is 2.36 times higher than non-anemia. Here's something more from the clinical floor. This is a study from the impact of pre-op anemia and post-op outcomes in non-cardiac surgery, a retrospective cohort study in the United States with the NESCIP database of almost 250,000 patients, of which 30% have been anemic, 69,000. And mild anemia, so just a little bit over 12 grams for, below 12 grams for women and 13 for men. There's already an increased odds ratio of 40% for mortality and 30 for morbidity. And interestingly, when you add transfusion to the picture, it even gets worse, doubling the mortality and 80% higher morbidity. So anemia is bad, transfusion doesn't improve it necessarily. The similar impression or similar picture we have in children. This is work from David Faroni from Toronto Sick Children Hospital and Susan Booby from Boston Children. You see incidence of in-hospital mortality with no anemia 0.1, with anemia 0.43, with no anemia but transfusion 0.4, with anemia and transfusion 1.45. So again, anemia is bad, transfusion doesn't improve it. And this is the, I would say, probably the best to date overview, a meta-analysis comprised of 24 studies with almost 1 million patients, looking into the association between pre-op anemia and mortality after surgery. And here in these studies, 39% of patients were anemic when they got onto the operating table. And the anemia was associated with a threefold increase of perioperative mortality, almost fourfold in kidney injury, twice as many hospital infections, and in the subpopulation of cardiac surgery patients, the stroke rate was up by 28%. And the anemia is the main driver, 5 times higher for red cell transfusion compared to the non-anemic patient. And then finally, adverse outcome of blood loss in the surgical arena. It's a no-brainer. Mortality, major morbidity, ICU and hospital lengths of stay and transfusion are also driven by acute blood loss. And we also always should keep in mind that the majority of blood loss is surgical blood loss. Only the remainder is coagulopathy. So what is the default position or reaction with either blood loss and bleeding and anemia? It is, of course, transfusion, and that's the reason why transfusion is the most common invasive procedure performed during hospitalization. That was in 2011, and at that time, the trend was still growing. And here's probably the first ever study that looked at it from a, let's say, more societal perspective. The first study to assess clinical and health outcomes associated with blood product transfusion across the full spectrum of procedures in the United States in hospitalized patients. And of these patients of 39 million, about 5.8% or 2.3 million were transfused. And after adjusting for age, gender, comorbidities, admission type, and DRG, transfusion was associated with a 1.7-fold increase of odds for death, 1.9 times higher odds of infection, an additional 2.5 days length of hospital stay. And the charges per patient transfused compared to the non-transfused were about $17,000 higher. The authors at the time encouraged the adoption of novel approaches to minimize intra-op and early post-op bleeding, reduce transfusion requirements, and most important, improve patient-level post-op outcomes and health-related quality of life. And you might now think, well, I'm missing now this connection, with this macroeconomic perspective, but here it is. If you just multiply the numbers, in 2004, this was an additional 40 billion extra charges for transfused patients just in the United States. And if you correct it for inflation in 2019 dollars, this was 92 billion additional dollars. So I think that's a lot of money. Here's some interesting data on perioperative transfusion and the prognosis of colorectal cancer surgery. The systematic review and meta-analysis with 170,000 patients and 36 studies. Overall survival is down by 67%, cancer-specific survival down by 66%, disease-free survival down by 83%. At the same time, all the complications, infections, cardiac complications, etc., are sometimes doubling in 1 year reoperation, almost tripling. We've put together, not only we, my colleagues and I in different publications, what are the different outcomes associated with transfusion in a dose-dependent relationship. And it's basically almost everything you can die from. And we have now about 56 observational studies, large observational studies with more than 6 million patients that demonstrate that the more transfusion they get, the more we see these outcomes, of course, including mortality and major morbidity and economically relevant increased lengths of ICU and hospital stay. We also have randomized controlled trials that do not look at the difference between no transfusion and transfusion, but of course restricted versus liberal. And there are many of these meta-analysis and systematic reviews. At least to my knowledge, there are 19 such systematic reviews. Interestingly, this is the one which has the largest delta in thresholds. That included the Villanueva, the Hebert, and the Lacroix study, all published in New England Journal of Medicine. And this study shows clearly that in-hospital mortality, total mortality, rebleeding, ACS, pulmonary edema, and bacterial infection in the transfused group are higher, or in the liberally group are much higher, significantly higher than the restricted. And this work is probably, when we think of what is going wrong in healthcare, this was the world's first consensus on the appropriateness of red cell transfusion. And the panel identified that 59% of all transfusions given are simply inappropriate, full stop. And then there's about 30% where there's a level of uncertainty, and only about 12% are appropriate. So when we look at this triad, we see there is a burden of hundreds of billions of dollars on a global scale. And the question is whether this can be changed into an opportunity. Before we do this, we just want to summarize what we learned in this first block, in this macro view. We wanted to understand the 21st century healthcare challenges. We understood that we are spending more money for healthcare that we actually do not have. We looked at the Great Tsunami that forces us to spend even more money for healthcare that we don't have. Even with the compression of morbidity and disability boundaries, we are facing this problem. Then we looked into the imperative for the healthcare sector, which is improved productivity. And although we say it's a no-brainer, we see things go wrong. So even if people don't follow probably the brain, And we see this enormous waste rate of resources. And we've seen in the schematic that there are, of course, many decision points where things can go and do go wrong. And then we had these three prime examples where things are going wrong, which was blood loss, anemia, and liberal transfusion. I'm not saying transfusion at all, but liberal transfusion or transfusion following the ignorance of the first two factors, namely anemia and blood loss. Now let's turn into the micro view, into the hospital level, the role of patient blood management to mitigate the healthcare crisis. And let's break it down now to the cost of anemia, blood loss, and transfusion in your hospital. Let's assume this is a representative sample of 100 surgical inpatients in your institution. And we know now from the literature that about that ratio of patients is anemic at admission. And we also have here a very interesting overview of the different types of surgery. And every of these blocks stands for just one study, one observational study in the different surgical specialties, from general to gynae, cardiac, orthopedic, etc. You see anemia is highly prevalent. So then we know that a large portion of patients is made anemic during the admission. And this is due to permissive attitude towards bleeding, to poor surgery, but also to excessive phlebotomy or venipunctures. Let me just show you this work from Colleen Koch from Cleveland Clinic, where she invited 9 other institutions and looked at her own institution with about 190,000 hospitalizations. The endpoint was mortality charges and lengths of stay on hospital-acquired anemia. And you see 74% of her population had hospital-acquired anemia from mild to moderate to severe. And you can see how mortality rates, lengths of stay, and charges are increasing significantly with the level of the hospital-acquired anemia. We did a similar study in Western Australia with 81,000 hospitalizations, similar endpoints, mortality and lengths of stay. And you see here a similar picture. In-hospital mortality for mild and moderate was 1.59 times higher, and severe 2.8 times, and lengths of stay 1.3 and 1.69 times higher. So we can say that during the course of from admission to discharge, about 57 at least are anemic. There's another paper from Matthew Warner in Anesthesia and Analgesia. He speaks of almost 80%. And then we have the additional problem that some of these folks are severely or moderate, at least moderately bleeding. And these few patients are those who consume your entire reservoir of blood components. And so we did a retrospective cohort study of all multi-day acute care inpatients discharged from 5 hospitals in Western Australia, so 90,000 patients. 5.3% of them were transfused, so we got the rate down already. And we saw that these patients with 1, 2, 3, or more than 10 units had this enormous increase in the cost rate for the hospital. We did this after adjusting for age, gender, admission type, DRGs, and patient complexity. This is a special score developed for an Australian hospital administrators group called Health Roundtable. So we saw that these transfused patients in Perth and in these 5 hospitals consumed an additional 77 million of the resources. And for example, here, hip replacement, these were the top 10 DRGs. Hip replacement without transfusion, adjusted cost about $17,500, adjusted cost with transfusion, $32,000. Here's another paper from the States by Michael Stokes. The impact of bleeding-related complications and or blood product transfusion on hospital costs in inpatient surgical patients. The bleeding rate was almost 30%. The bleeding compared to the non-bleeding had a 6 days longer mean length of hospital stay. And the incremental cost per per hospitalization associated with bleeding-related complications were between $3,000 for hip replacement to about $17,000 for spinal surgery. And here's the graph. You can see this is all, again, corrective confounders with and without transfusion. So interesting, what they said is interventions for bleeding control were relatively uncommon, occurring in only 2.5% of all surgical patients. Things go wrong. And the conclusion, this supports implementation of blood conservation strategies. So coming back to our 9 out of 100 surgical patients of your institutions, we can clearly say, and you go back to your own hospital files and your own data, and you will find out that the transfused patients are your institution's loss leaders. Now, that brings us to the rationale behind PBM. As you have seen this now several times, but this is not something that we have to accept as it is, because we can modify these risk factors for adverse outcomes. We can modify the first one by optimization of the red cell mass by stimulating the patient's erythropoiesis. We can modify blood loss and bleeding by a systematic approach to minimize blood loss and bleeding that includes surgical, anesthesiological, and hemostasiological modalities. And finally, leveraging the physiological reserve body. And we have split this into the 3 phases of pre, intra, and post-op. You might have seen this in various talks and publications already. So this is now called the 9-field matrix of patient blood management, where you have the different modalities that you can apply in a patient-tailored way. So what happens if you apply PBM? Here's an example from the world's largest heart center in Beijing. It's the Fuwai Hospital. And my friend and colleague, Professor Hong Wen Ji, has implemented PBM in the year 2009. Interesting, this heart center has about 15,000 open heart surgeries per year. And what you see here is a mortality rate of 0.44. It's extremely low. We know that in heart surgery, in most Western institutions, we have a mortality rate between 2 and 3%. They have 0.44. And here is what happened since the implementation of PBM in that institution. The blue ones are red blood cells, the transfusion rate, and the green one is FFP. And by the way, their blood bags are half the size of ours. So the transfusion rate is to look at even, it's even lower. So it started 70%, it's now down to about 23.9% for red cells and about 11% for FFP. And the average in the People's Republic of China is still almost 60%. So they really showed a difference. What did they do? First of all, they involved every surgeon into the program. It is a multidisciplinary collaboration. And then they set specific measures. They have an anemia treatment program. Of course, they look at meticulous surgical hemostasis, use routinely antifibrinolytics, use routinely cell salvage when a blood loss of more than 500 mL is expected. They reduce the CBP volume, the CBP circuit volume. They use routinely viscoelastic testing to save time in order to define whether it's a systemic bleeding or a surgical bleeding. They have a very strict adherence to restrictive transfusion thresholds, and they evaluate every single procedure by surgeon and anesthetist when it's somewhere when there's an outline. They have procedure-based benchmarking. They have a bonus award system, and they see blood transfusion or the reduction of blood transfusion as a quality control indicator in cardiac surgery, and reduce with this not only the transfusion utilization, but of course the prognosis of the patient, which is shown by this abstract published in the Lancet from the group in Beijing. It's called Outcomes After Multidisciplinary Blood Management in Adult Patients Undergoing Cardiac Surgery. As I said, they started in 2009, and they saw a reduction in the length of stay in cardiac surgery from 10.5 to 7.5 days. And in mortality, they reduced from 1.2 to 0.5, and most recently to 0.44. Here's work from Johns Hopkins, where they implemented a system and where they had a return of investment in the first year of 400%. I double-checked the publication. They had a little fault in the calculation, and in fact, it's 800%. In Zurich, they have shown with the patient blood management monitoring and feedback program to reduce the cost for blood products over 4 years by almost 13 million Swiss francs. And here's some interesting work on the screening and treating of pre-op anemia and suboptimal iron stores in elective colorectal surgery in Australia. In our PBM group, it's a cost effectiveness analysis. It's done in the flagship hospital in Western Australia. And it's a pre and post intervention. We have, as a comparator, 239 non-screened colorectal surgery patients, and we have 441 screened for, as I said, anemia and suboptimal iron stores. We found that 41% needed intravenous iron. The mean costs for all the 441 patients for the screening and treatment were about $332. We reduced the transfusions by more than 50% on a per 1,000 patient basis, but we also reduced on a per patient basis the cost per treatment of total treatment by $3,776. So we are clearly in the best quadrant to be, where we have a better outcome for less cost, which is something you don't have too often in healthcare. Now, on a per 1,000 patient basis, this is almost $4 million savings. And here is the slide, coming to the slide that I showed you in the very beginning of my presentation today. This is, again, the world's largest PBM study in Western Australia, where we included all tertiary hospitals, including the Women and Children Hospital, and where a number of private institutions also started to join our group. And I asked the question, how did we achieve these outstanding results? And we achieved it simply by implementing all 3 pillars of patient blood management. And it has become a standard of care in Western Australia. And so not only that we saved this amount of money, in fact, in the 4th year, we saved about 40 million of these 100 million. And since then, we are saving the system at least 40 million every consecutive year since. Meanwhile, we have also seen in the literature a multimodal PBM program, systematic review and meta-analysis, including 17 studies from around the world. In some of them, we have, my colleagues and I have been directly involved, and of course, the Australian study is included here. And Donat Spahn summarized it in this article in the Annals of Surgery, just looking at the surgical patients. So not at the 600,000 that we've seen before from Australia alone, that was medical and surgical. Here's just the surgical patients of the 17 studies. And you can see a massive reduction of transfusion rate, a massive reduction of major complications, and a reduction of 11% of in-hospital mortality in surgical populations. Mayo Clinic, Johns Hopkins, Cleveland Clinic, Zurich, TriHealth, they are all offering now PBM programs. Here is Jay Batt, the Senior Vice President and CMO of the American Hospital Association. He says, while improving health and improving quality, the first thing you've got to do is appropriate blood management in inpatient services. Here is a picture of the flagship hospital of Korea. It's the Annam Hospital in Seoul. And my good friend and colleague, Professor Park Jong-hoon, he is a oncological surgeon and also the dean of the vice dean of the Korea University Faculty of Medicine. He says, with the opening of this hospital, I'll make this the safest hospital in Korea. PBM is one of the tools to achieve this goal, he said. And last but not least, the essential role of PBM in a pandemic, a call for action. This was put together by 43 PBM experts from 17, I think, countries. And it shows clearly that with anemia management, with better management of blood loss and coagulopathy, ABC, you can save tons of allogenic blood products and therefore help your institution even in times of so-called blood shortages to keep up most of the operations. So the word of Donald Spahn, not implementing PBM, represents substandard care. And PBM is now also mandated by the World Health Organization. It has been endorsed in 2010, but now it's mandated in this action framework for the next 3 years. Their definition of PBM is a set of evidence-based practices to optimize medical and surgical patient outcomes through preservation of the patient's own blood. And they have defined 6 strategic objectives. One of them is the effective implementation of PBM to optimize clinical practice. They set off transfusion, and we had a severe battle with them, but they now understand that this is probably the wrong term because it's not about reducing transfusion, it's about improving patient outcomes. And so there is a very powerful policy brief in preparation that will be released by the World Health Organization, most likely next month. And I encourage you to Google now and then PBM and WHO, and then you will find some very interesting thoughts and concepts that might remind you of that presentation you saw today. So before I come to the summary, here's now the latest definition of PBM. It's slightly changed. It's now called a patient-centric, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. And these are the 4 foundations and societies that took the initiative, but meanwhile, this is endorsed by the American Society of Anesthesiologists or by the Korean Society of Anesthesiologists, the Malaysian Society of Hematology, the Society of Cardiovascular Anesthesiologists, and interestingly also by the South African National Blood Service, because they are facing chronic shortages of product, and they feel that the best service that they can do to their service is implementing and promoting PBM. So here's now the summary. We went through the macro view already, and now we did the micro view. The micro view told us the cost of anemia, blood loss, and transfusion in your hospital, most likely, is usually under-recognized. And what is clear from all the databases I've ever come across, the transfused patients are the loss leaders of each institution. The rationale behind PBM is actually not very complicated. It's not rocket science. It's simply optimizing red cell mass, minimizing blood loss and bleeding, and do a little bit of support work to leverage the tolerance of anemia in sick patients. The multiple wins with PBM are for patients, for physicians, for hospitals, and the society. And this is now recognized by leading hospitals and professional societies around the globe, and it's mandated by the WHO. So thank you for your attention. I think we can go into the discussion.
Thank you very much, Professor Hofmann, for your very interesting insights. I was especially impressed how you build the bridge between the economic and societal development in healthcare onto patient blood management. So let's take a look if you have some questions. So we have a question. You mentioned also in the summary that the rationale behind patient blood management is a no-brainer. That is not rocket science, but looking at it from an implementation point of view, what are the biggest errors that can be done in hospital when starting with patient blood management?
Well, the biggest error is probably that people say, well, we have guidelines out there, let's start and do it. This wouldn't work at all. You know that guidelines are necessary conditions, but by far not sufficient conditions. And so there are, I would say, 4 factors to take into consideration to have a good chance to implement PBM successfully. Number 1, you have to have an implementation methodology. There are several schools of thought in how you implement something in the airline industry, in the insurance industry, in the car industry, or in a hospital system. We chose the Cotter model, the 9-step Cotter model. John Cotter is the head of the Institute of Change Management in Harvard, and he has published extensively on change management. And we feel that the Cotter model is really the one to go for, especially because with PBM you are not up against evidence. I mean, the evidence is totally on side of PBM. You are up against culture. And so an implementation methodology is number 1. Number 2 is you have to put in place governance, which is intertwined with the Cotter model. Governance means you have to have an organization. Within the organization, you have to have a task force that has the full support of the board of directors. You have to have a budget, and I'm saying that PBM doesn't cost money. It is just reallocation of existing resources, but you get a bigger bang for the dollar. So you move it from left to right or right to left. And you've seen the slide from Johns Hopkins, where they saved in the first year just to my calculation, 800 to their calculation, 400% of the investment. So the governance needs to have the people, the endorsement, the authority, and the budget in terms of we can decide how to spend the money in the PBM program, and that will pay back immediately. And then the third one is clearly you have to work closely with the IT department. And I know this is a big challenge because the IT department is always overwhelmed with work, with tasks. But when you are able to convince your board of directors or your hospital director, and you tell them, look, this is the return, this is something that gives you immediate returns with better outcomes, then it's, again, a no-brainer that it has to have a number 1 priority, because you don't find a lot of such situations in healthcare. And then the fourth component is an educational program. So I repeat, implementation methodology, governance, IT cooperation, and an educational program.
Thank you so much, Professor Hofmann, for answering this question. I hope it was sufficiently answered for the audience. So I just want to repeat for the audience, if you haven't found the question button yet, it's in the upper left corner where you see 4 lines. Please click on the 4 lines, and then you will see the question button and the form where you can answer. You can enter your question, of course. We have another question, and it's related to the answer that you just gave us. So And change management seems to be central for a successful implementation. Who should be involved and how to go about it?
Probably I can show you a few slides to answer this, a few additional slides, which I have in my supplement here because I know the common questions. Let me see if I can reopen this here. You see, what we see is this famous critically hematocrit, right? So all these professionals are more or less responsible whether the patient is being transfused or not transfused. And they all look at this critical hematocrit. Oops. And it's a lab-driven monotherapy given blood, regardless of the underlying cause of disease. So they didn't look at the anemia, because if they had looked at the anemia, you know, in the operating, no elective patient would hit the operating table anemic. But because they don't look at the anemia, they have to face quite often a situation where the patient is so anemic, acutely anemic, that they have to give the transfusion. So what I'm saying here, how low can I go before administering a transfusion is the wrong question for a clinician to start with. But when you ask who should be involved, then basically all of them must be involved because they are the culprits. They are the ones who should know better. And they have to really change this product focus to this new focus and ask themselves, how can I preempt that my patient gets even near to a critical point? So in other words, what can I do to minimize or eliminate the underlying cause of anemia and blood loss to improve patient outcomes, even for patients not at risk of transfusion? And this means, and here's the culture change that you have ahead of you when you want to implement. Is there uncorrected micronutrient deficiencies? Do you have an algorithm to check this? You know, are you routinely in a position to detect such deficiencies? Then is there uncorrected anemia? Is there permissive surgical blood loss? Do we have a culture problem in terms of we just allow for blood loss? Do we have excessive iatrogenic blood loss? Do we have this excessive rate of phlebotomies? Do we have a poorly managed disease-related blood loss? For instance, a gastroenterology patient that is bleeding on a Saturday evening, and you let him bleed because the department will be fully occupied the next Monday, and you transfuse him meanwhile. Or is there a poorly managed coagulopathy? Are we losing too much time with the standard lab testing rather than applying point of care testing? And do we have a behavior-based transfusion practice? So are we dealing with complacency and ignorance? Are we having these missed opportunities? And so if this is the situation, I skipped these ones. Here's the 8-step Carter model. You have to create a sense of urgency for change, and you have to involve all these clinicians that I just described in my earlier slide. Of course, the number one group that you have to involve is anesthetists and intensivists, because they basically decide over 35 to 40% of all transfusions anyway. Another big group that's important is obstetricians, gynecologists, of course, oncologists, hematologists. And you have to really disseminate this urgency. And then you form a powerful PBM coalition where you invite those who lean towards PBM, who understand the concept, who are potential, potential champions for PBM. And then with these people, with this first group, you create a vision for PBM in your hospital. And this is where you have a climate for change. And once you have achieved this, you go for more proactive stakeholder engagement, and you start communicating the vision across the entire institution, sister institutions. You start removing your obstacles, and you create short-term wins. And you can do this because you are a powerful coalition. This power has been given to you by your hospital administrators. Otherwise, forget about it. And then you can get buy-in, and you reach a level of strength and mobilization. Then you build on the change and you anchor this in the culture. So this is what I would give you as a long-winded answer, but I think that's necessary to mention when the question comes up about obstacles.
Definitely. Yeah, it was very interesting to see how you use the Kotter model for this change process, which of course it is. And we have another question here. You mentioned IT before and how it is important, how to collaborate with this department. So the question says the informatic systems in Switzerland are very heterogeneous and not always on top of technology. Is a modern IT system a prerequisite to introduce patient blood management? I would say, of course, yes, but which are the prerequisites that are needed from an IT point of view without going too much into technical detail?
Okay. First of all, it shouldn't be a big problem in Switzerland. Ronald Spahn has advanced very much with his IT system in the OSZ. And I think it's a very sophisticated and at the same time easy to use system. I'm right now involved in a project in Ticino, in Bellinzona, Mendrisio, Lugano, and what is the fourth place? I forgot one. Where we implement PBM, but with a tremendous support from the IT system. And we found that once they understood what the tasks are, they quickly identified in their data warehouse what linkages they have to create. I mean, usually you have the financial system, you have the laboratory information system, and you have the transfusion medicine information system. So LIS, TIS, and KISS, laboratory, Krankenhaus, hospital, and laboratory. And usually you find sufficient information where you can have per ICD-10 code or per OPS code, your transfusion rate, your transfusion index, which is the number of units transfused per transfused patient, by product type, FFP platelets, red blood cells. You usually find the lowest measured hemoglobin level. You find coagulation parameters, INR, PTT. So we found that it is not a very big task to find at least the basic information and to link this electronically to start a PBM program within a relatively short time.
Okay, thank you for that. We have another question regarding hospitals. So the examples that you've shown and that we talked about are all quite large hospitals. What about implementation of PBM in smaller Swiss hospitals that are currently already using few transfusions?
Well, I would say that the principles, I have little experience in the economies of scale, let's say, when we implement in smaller institutions. However, from an ethical perspective and also from an economic perspective, I mean, every transfusion that can be avoided simply through a reasonable pre-op treatment of my patient, of your patient, is worthwhile. And I don't know how big the return of investment would be in these hospitals. In fact, it would be an interesting undertaking to study the return of investment in these institutions, smaller institutions. But I'm convinced that PBM is always the better approach. And if I'm a patient, I wish to be treated by the principles of PBM. And it's interestingly in this upcoming policy brief of the World Health Organization, where they address anemia at the broadest scale and said family doctors should be much more aware about anemia, general practitioners. Every blood draw, every phlebotomy should be considered before it's being done. We know that blood services are constantly putting out advertisements saying every drop counts, right? But I think every drop in the patient counts. We have to start early with thinking along these lines. What can I do to minimize blood loss, even in patients that will probably never see a transfusion, or in areas in the world where we don't have transfusions available anyway? We should do every reasonable effort to preserve and manage the patient's own time.
So you would say in a small hospital, even if it's unknown how large the financial impact would be, that from a medical and ethical point of view, it is the right thing to do?
Correct.
Okay. Good. And then I think one last question. Considering the wealth of scientific and economical evidence that you showed us in your presentation, is there still any relevant information missing? Or if somebody is in the audience and wants to implement PBM, is that all they need to know?
I mean, we always have look at new horizons. There's a group in San Diego that looks for years now for artificial oxygen carriers, and it looks like they are before another potential breakthrough, especially for patients with very low hemoglobins, where you probably could bridge the gap between the current acute anemia and the kicking in of the patient's own erythropoietic system. But I mean, by and large, we have all the ingredients, and we have enough evidence for all the ingredients. And there are so simple things like keeping the patient normothermic, clearly avoids unnecessary blood loss, or the positioning of the patient. Of the operating side relative to the heart, following the law of gravity, but people have to think about it. Or the minimization of phlebotomies to the really required amount and frequency, or to use the time, especially in obstetric patients, when we know that the mother is anemic. Well, there's plenty of time and opportunity to identify, to detect the anemia and to treat it. So I think we have so many very simple modalities, but the awareness is not there. So it's really a process, again, of culture and creating awareness. And the majority of patients can be treated with a minimal set of PBM principles.
Thank you so much for this last answer, and thanks again for your very interesting presentation. It really helped me, and I also hope it was the same with the audience, to understand that it really is a culture change, a paradigm shift that just needs time. Okay, so
thank you.
Thanks so much. We're coming to the end of this session, and I have some information that I will give you regarding the next events. Tomorrow already will be the next web app presentation. It will be at 5:30, and it's HRF EF Cocktail Part 3. And the next FomF Presents Fortbildung will be on the 2nd and 3rd of September at the Hausart Fortbildungstage in Bern. I hope you enjoyed this event just as much as I did, and I hope to see you all again and wish you a nice evening. Thanks for your participation. Thank you, Professor Hofmann.